Hey guys, you're watching the Best Practices Show. We're taking a look at the best business practices from the best dental practices all across the country. And as you're looking at a way to create better relationships with your patients, I've got the expert today in how we're going to talk about creating partnerships with your patients for greater diagnosis with somebody who's been a restorative dentist and is now an orthodontist. And this guy is awesome. So you don't want to miss this. Do me a favor, grab a pen and hit the share button. We'll see you in a second. Hey guys, welcome back to the Best Practices Show. I am so pumped that you're on. And again, we're just loving this with all the feedback we're getting. Keep sending it to us, and we're going to keep putting together great shows to give you the information that you're looking for. So, and today's guest, one of my favorite, been a friend of mine for a long time, and you're going to see why in just a little bit. So as we jump into that, I'll kind of uncover a little bit of his story, and then we're going to have him tell the rest of his story. But before we get started, just a couple show notes. We are shooting this particular episode live on Facebook. And if you're watching this live and you have a question, please add a question to the feed, and I will ask Glenn himself to answer the question, and we'll get it straight from the expert. And we love the question so much that we're giving away a free Apple iWatch every single week to the best question or series of questions asked, and 2 tickets to Activate, which is our practice growth seminar. And you don't want to miss that. It's almost sold out for June. So if you're thinking about going, get registered now. And actually last week's winner was Deepak Madhav, who asked a series of great questions. And so thank you, buddy. Really, really appreciate that. And it's on its way to you. Also, too, we're on iTunes. So if you can't watch all these, and please don't watch them while you're driving. Somebody said I'm watching them while I'm driving. Don't do that, okay? Unless you've got hands-free driving or something. Don't do that, period. So my guest today, a great friend of mine, and has one of the wildest journeys in all of dentistry. And I'm going to do my introduction on him, and then I'm going to ask him to say a few words about his journey. But being involved with the Seattle Study Club, which is an incredible blessing for me, about 10 years ago, got a chance to meet some incredible speakers. And one of those speakers was brilliant, not only in the communication side, the photography side of things. He was speaking everywhere, and one day woke up and decided he didn't want to stay on the path of restorative dentistry and changed directions and became an orthodontist. And Glenn, that's pretty wild, man. Can you tell people who you are and what you're doing and a little bit about your story? Because your story is one of the wildest stories I've ever heard in dentistry.
Well, thanks. I'd be happy to. And just a question for you. Can I ask questions so I can win an Apple Watch? Is that okay?
Absolutely. But they got to be good, thoughtful questions. Good questions. I love great questions.
I'm taking it this week. I'm saying it now.
Deal.
So, yeah, my story is a bit different. It reads like a country western song, I think. So I'm a third-generation dentist. My dad was a dentist. My grandfather was a dentist. Grew up with it in my blood. Used to assist in my dad's office, just loved dentistry, knew I wanted to be a dentist from the time I was a kid for many of the reasons that a lot of the people watching the show wanted to be a dentist. Came out of school, found some great stuff in New York where I was practicing, but I felt like it was a little bit of a dog-eat-dog world for me. It was a little bit too much, and my wife and I decided we'd move out to Seattle, where, if you think about the 1990s, mid-90s in Seattle, that was sort of like the center of the dental hub, right? You had all these great names: John Coys, Vince Kokich, Dave Matthews, Frank Spear, Ward Small. I mean, I could go on and on and on. So I figured if I went out there, the brilliance of that area, the people who were out there would just trickle down somehow. And, oddly enough, one of the first people I met, I went out there, he took me wing, introduced me to a lot of folks, and to this day, I will tell you I was the luckiest general dentist in the world, because here I am meeting all these great people, learning from them in a way that you just don't get. And so I was trying to become the best restorative dentist I could ever become, learning as much as I could, accidentally fell into lecturing, just happened by accident, where because of my mentors teaching me photography, other people wanted to learn it, and little by little, word started getting around, and I became this crazy guy from Seattle who was just teaching photography. And I started traveling the world teaching photography. And I realized that if I taught them photography, I was just teaching them like a skill. It wasn't translating into anything good for their practice or their patients. So I started trying to do all the reading and learning I could about how to use photography to change their lives. And so I started teaching digital code diagnosis, and I started doing that part of it. And then in 2010, I had my dream practice. Everything was, I mean, I couldn't say I could be any more blessed than I was in 2010. Things were wonderful. And my wife was starting to go through a real depression from the weather of Seattle. You hear about it, but it really started to beat her up. And she just turned to me and said, you know, my family's on the East Coast. The weather's killing me. Can we just get out of Seattle? And I said, no question. I love you to death. Anything for you. My wife comes before my practice.
Right.
And so it was funny because about 10 years earlier, one of my mentors, who's an orthodontist, said, Glenn, you know all this occlusion, you know interdisciplinary care, you should go back to ortho, learn how to be an orthodontist, and then you'll be my partner, and we'll do some cool interdisciplinary stuff together. And I said, you know what, it's just not the responsible thing to do. And then when my wife came to me and said she wanted to move, I said, well, if I'm going to start all over again, it's still not the responsible thing to do. But I asked her permission, and she said yes. And I went back to ortho. I think I was one of the oldest people in the United States to ever go back. I think when I started, I was 44 or 45 years old. I was almost 45 when I started ortho with 3 kids, a wife, and we picked up our lives, went to Florida, went back to school, graduated there in 2014, and went to Dallas, which is where I am now. And so I like to tell people I'm just a simple country orthodontist doing the best I can. Yeah. And that's my story to some extent.
That's awesome. That's awesome. And you've seen it from both lenses. I mean, you as an instructor, as a speaker, being out there, why ortho? Like just get, of all of the, areas you could have gone into, tell us why ortho.
It's a great question. There's a lot of good reasons. I can't speak for other orthodontists, but I can tell you that I personally love restorative dentistry. I miss it every single day. It's an amazing profession, the way we get to change people's lives. Orthodontics is different. There's a lot less done with these and a lot more done with thinking. It's like a chess match. You have to sort of work out the whole plan before you start. And I'm not saying we don't do that with restorative dentistry, but anybody who's done restorative dentistry or any other specialty knows it's hard on the body. I was getting a little bit of shoulder problems. I was starting to get a little bit of carpal tunnel. And oddly enough, I was starting to lose hearing in my right ear from the handpiece. And all of those things play a small role. But the 2 biggest reasons I went into it, really, the first, I know it sounds really funny when I say this, but there's a big difference in the ortho world when people come in to see you. Every day people would come to see me in the restorative world and say, hey, doc, I love you. You're a great guy, but I hate being here. I heard that every day, and it really wears you down after a while. And so here in ortho, nobody ever says that. Everybody comes in like, hey, they do the opposite. I like being here, but when am I going to get done? Right? When are these coming off? So that was one of the big reasons why I chose to go into ortho. And the other was, as a restorative dentist, every single thing we do is resective in some way. You have a cavity, I got to cut it out. You've got a wisdom tooth, I need to take it out. You've got a devitalized nerve, I've got to remove it. Everything was you go in and you take out. Ortho, you're just working with or against biology to sort of move things around. And I really, really enjoy the non-invasiveness of it because I had all these patients in my practice where I'm prepping every tooth in the mouth, setting up a beautiful occlusion. And one day it dawned on me, maybe I can go back in time and treat these kids when they're 12, get their occlusion perfect, and so that they don't need that full mouth reconstruction when they're 45, 50, 55 years old. So instead of prepping the teeth, let's move the teeth. And that was really what drove me in that direction.
Yeah, that's awesome, buddy. That is awesome. And this particular topic that we're going to uncover today, this is really huge because you've seen it from both lenses. And I want to talk about why that's important. But I also want to start with the thing that you and I have talked about, the one piece that gets left out of the interdisciplinary discussion is ortho. Would you agree with that completely or limited, in agreement to that?
I think that the clinicians who sort of cross that threshold and really, really get it, sort of the master clinicians, the ones that I look up to and did look up to when I was a restorative dentist, I think they understand that restorative dentistry ortho is a vital part of setting up a restorative case, particularly in adults who are missing teeth. I think dental schools don't, I'm not going to blame, but I'm going to say, the responsibility for education goes two directions. I think the orthodontic departments insulate themselves tremendously from the restorative dentists and everybody else, because you can ask anybody who's watching the show right now and ask them, how much ortho experience did you get or exposure when you were in dental school? And the answer is typically virtually none. And on the other side of it, the restorative faculty are typically not working on bringing the ortho in. So I don't think there's any fault of the dentists, but I think like folks like myself who made ortho an integral part of our practice by having a really good team and referring out to a good orthodontist, I did more crown and bridge. I did more restorative work on the cases that went to the orthodontist, because once the teeth were put where they belonged, I needed to restore back all the wear from the teeth being in the wrong place. And so I say this as an orthodontist, but I would offer this as a word of advice to every restorative dentist watching your show right now. My goal as a restorative dentist and as an orthodontist was to learn more and more about less and less. So my practice was, if you needed endo, I referred you to the best endodontist in my city. If you needed ortho, I sent you to the best orthodontist. If you needed perio, I sent you to the best perio and wisdom teeth, etc. I sent to my best oral surgeon. And at the end of the day, the more I started to learn about working with an amazing specialist, the better my bottom line was and the busier I got. I cannot explain to you why. I can't tell you any particular link, but every dentist I know who tries to learn more and more about less and less becomes busier and makes better profit. And I don't know why that is, but ortho is one of those things that I think just unfortunately they're not educated enough about, and we're not educated enough about bringing them into the fold.
Right. I have a guess on why that is. It's because you're narrowing your scope and you spend more time doing the things that you experience joy with, which naturally compounds itself into a better result in any profession. So, so I love that, buddy. And now let's talk about this too, because you're passionate about making the patient a partner. And I use the word diagnosis, but you said, it's case acceptance. So talk about that. How does that work in making your patient a partner, and how do you see that?
Okay, great question. So I think anything we learn has, I think, two completely different ways to dissect it. So let's take clinical photography. You can take exceptional images and become really good at it. But how does that translate over to the patient experience and our practice involvement? So you can do a really good crown prep and be the best in the city. So great, you did a great crown prep. What does that translate into, right? That's a technician. And if anybody's ever read The E-Myth by Michael Gerber, one of my favorite books ever, we all wear three hats. We wear the entrepreneur, we wear the technician, and the marketer, the manager. So the technician in us usually gets stuck because that's what we are. So here we have great clinical photography, and we all show our images to each other and say, wow, look at that image, look at that image. But do we ever stop and ask ourselves, what does that image do for us? What can it do for us? How can it enhance the patient experience? How can it make our practices stronger? I got tired of patients coming into the office and sitting down in the chair at 8 a.m. And before I came in the room, they turn to the assistant and say, just before we start, I need to speak to the doctor for a few minutes to ask, why are we doing this again? Or somebody, you're prepping, you're supposed to prep a quadrant of crowns. And before you start, they go, why are we doing this? Or worse yet, which, knock on wood, I rarely heard, but you prepped a quadrant of crowns and they ask you 2 months later, why did we do that again? So there's where patients learn really well through a process that I learned about in an airport, of all places, on my way back from a lecture. Like yourself, Kirk, we're not the shy wallflowers. We have a tendency to interact with our surroundings a little bit.
Right.
And I was sitting waiting for a flight, and there was a nurse there. And this is probably 10, 12 years ago. And she said, what are you doing? I said, I just came back from a clinical photography lecture I was giving, and she was interested in learning more about it. And I told her kind of what I was doing and how I talked to patients about using the images for growth and for making them your partner. And she said, oh, that's motivational interviewing. Now, this is about a decade ago. And I said, well, what's that? And believe it or not, I got back to my office and she had taken my business card and she mailed me a book on, I mean, talk about the abundance mentality, sort of like, pay it forward. Mm-hmm. She sent me a book on motivational interviewing, which I read, and I sort of adapted that to clinical photography. And what it basically means is, instead of me showing you a picture of teeth and saying, what we all do is, do you see that picture of, sorry for pointing, but do you see that picture of that crown right there? You see that tooth there with that filling in it that's really, really big and dark. Right here, there's a cavity, and I want to take out that filling, and it's too big to do another filling, so we need to do a crown. And while we're there, the tooth next to it needs some, and that's the way we talk to patients. And then we question, why don't they understand what we're talking about? And why don't they own it? Why don't they make it their responsibility? Why does it become our problem to own their problem? And in my practice at that point, I said, you know what? It's their problem, but I'll help them solve it. And so motivational interviewing means, instead of doing what I just did a minute ago, I take my photo and I say, do you see this tooth over here? When you look at it, what do you see? And you shut up. Mm-hmm. And they say, oh, I see a filling. And you say, exactly. And what do you see, that brown stuff around the edge of the filling there? And they say, a cavity? It's almost like My Cousin Vinny, that trial scene? Right? And you walk them through step by step until the end goal is, yeah, you're right, that is a cavity. And, chances are, if there's a cavity there, do you think there's a cavity forming underneath it? And if I take out this filling, which is so wide already, do you think it's going to be so wide that it might break the tooth if I put a new one in? They'll say yes. And you get them to the point where they say to you, yes, yeah, I think I do need a crown. Mm-hmm. And it's out of their mouth. And then you look at them and say, well, would you like a solution to this problem? Because I'm happy to offer you one. Right. So I know to those people out there listening who know the difference between case presentation and digital co-diagnosis, they're going to say that the difference is just small. We're using a computer, we're showing patients stuff. But if you take it from the point of view that I'm trying to make a case to the jury, instead of trying to lead someone on a journey, you'll find a big difference. And the moment they hear the words come out of their mouth, is that a cavity? I think I need something to fix there. I think I need a crown. Now they own it, and you will find they'll stop asking the questions that annoy us the most, like, how much of this does my insurance cover? I only have $1,000. I can only spend $1,000 a year. I love that one. Mm-hmm. I can only spend $1,000 a year. And the moment they see the cavity, the moment they recognize the problem, the moment they see the 3 teeth in a row that have the problem, and it's come out of their mouth, all of a sudden they take ownership. It's not your problem anymore. Right. And it's such a liberating concept that now they say to you, so which one of these should I do first? And you say to them, well, all 3 have cavities. It's not really my call. I would tell you to do all of them at once unless you've got a reason not to. If you did this one and then this one broke, would you feel bad about that? And they say yes. I said, then either you make the call, or my suggestion is we do them all at once. And they say, okay. And I know it sounds funny, and it's not about money. It's about helping people. And the money will come. But I will tell you that the first week I did this, Kurt, the first week, the first patient, and it says actual results may vary. The first patient I did this for, I showed them a presentation in PowerPoint. Mm-hmm. I came back into the room. I hadn't said a word to them. They only saw the pictures. They turned to me and said, what kind of financing do you accept? And I said, for what? Mm-hmm. They said, I saw all the problems. It was a $22,000 case. I didn't say a word, and they were begging me to do it. Later that week, there was another case for about $45,000. I didn't say a word. The moment they see these images, high quality, and you don't try to sell them into what they need, they instantly take ownership. And even if they can't afford to do it now, they will never go down the block and say to the guy down the block, that guy Krieger's a thief. He tried to talk me into doing X or Y, because now they understand it. And if you're doing it really well, you can always spot your patient at a cocktail party because they're the one who actually speaks like a dentist and understands what their problem is.
Yeah, that is so cool. Now, was this hard to do in that first week? Because, one of the things that we've learned is that once you learn a new concept, it's very hard to empathize with how you were before you learned that concept. I learned that at Symposium this year, because that was a big week for you. Was this hard to do? And then was it something that you just had to be very, your awareness had to be high that, hey, look, I got to stop talking? Because sometimes dentists love to talk and we call it verbal diarrhea. You call it whatever you want. People love to talk. So,
yeah, I love to talk more than most of them. And it sounds kind of ironic and funny that I'm the guy telling people to shut up. Mm-hmm. But it's true. We tend to be our own worst enemies. We tend to sabotage ourselves. And again, let's go back to Michael Gerber and the E-Myth. We speak like technicians. That's what we do. If I ever hear an assistant in a restorative practice call something an occlusal, if I ever hear them talk about tooth number 19, that's a good chance for us to sort of redirect them into understanding that when we sit as patients in rooms, we want straight talk and we want to understand. And I think it's important for us to understand as well that if you understand the different personality types, not everybody takes to this as easily, right? The engineering types are going to be very, very good with this.
Right.
The touchy-feely types, it's going to take a little longer. But the key to this, Kirk, is it requires trained verbal skills. It's unusual when you just show images and someone goes, wow, sign me up. Mm-hmm. But if you think about it, and of course you have to practice it, right? It just, can I digress for just a second about something I learned this week?
Absolutely.
So this week, in one of my ortho groups, I had a web conference with a guy named Eduardo Briceno. He's a TED Talk guy. You can find his TED Talk online. He has like 1.5 million hits. And I just did a moonshot. I sent him an email and said, I loved your TED Talk. Would you ever mind talking to my group? And he said, sure. So I had 20 minutes with him. And his big talk is about the learning zone versus the working zone. And he uses the analogy of a tightrope walker. A tightrope walker does all these amazing tricks on the high wire with no net. But when they want to learn a new trick, do they go 60 feet up in the air and start doing flips with no net? Of course not. They do it in a very safe, comfortable place, a foot over a foam pit, because they want to make the learning environment safe with no risk of any kind. And his point is, we don't do that enough. And it sort of struck me that we never do that in dentistry. We learn a new technique, we play with it a little bit, we go right into clinic, it doesn't work, and then we say, well, that doesn't work. And 2 weeks later, they're back into their old engram. Yeah. So my thought was, you need to practice this stuff in your team meetings, which is something you can talk a lot about team meetings, right? So, but this is where, if you want to start doing this stuff, you have to practice two things. You've got to practice the photos and you got to practice the verbal skills. So going back to your original question, you just can't go into a room, shut up, and hope it happens. Right. You've got to create the verbal skills to recognize the personality type you're with, and then walk them down the correct path. So now I'm getting into all the psychobabble stuff. But again, if you want to have what others don't have, you've got to do what others don't do. Right. So if it were really easy, everybody would be doing it. And it is really easy, but it just takes time. So I would suggest that first they have to get great photos, and you can get that any number of ways, because it's not going to happen with a web, the intraoral camera that you shoot one picture of, because then you're selling tooth by tooth dentistry. And we can talk about that if you want to. But you need to take good photos, and there's ways to get that. There's a million ways out there. And you need to have the verbal skills. And the verbal skills are easy. You put one of your assistants in the chair, you show some pictures, and you tell them, be a pain in the butt patient. Grill me on everything. Mm-hmm. And you just walk them through the path. And it hurts and it's uncomfortable. But if growth is what you really want, that's how you'll get there. And again, we'll talk ourselves out of cases a lot of the time. And it's important, Kirk, if you don't mind my adding one more thing.
Please.
People, as well as anybody, that case acceptance does not happen when you present the case. It happened way earlier. Mm-hmm. And so, again, I started as a photography guy, and then I would go to club after club, I'd go to lecture after lecture, and people would email me and text me, and I realized that giving them just the photos was nothing. I needed to throw myself into the world of education and learn as much as I could about the process of selling, the psychology of selling, of new patient experiences. And so I believe that case acceptance begins when the phone is answered in your office for the new patient call. I think in today's day and age, it begins with what you have on your website, and how you're advertising. And I think people, they start making an idea of who you are, and if done properly, I think digital co-diagnosis is that cherry on top that brings everything you've done up until that point together and says, I know you love me, I know you love me, I know you love me. Now you know why you love me. Like that's how I kind of see it.
Yeah. And buddy, I think you're spot on. Matter of fact, I know you're spot on. People don't buy the product. They buy the product of the product, which is the ultimate experience. And a lot of times we pick restaurants that we go to because of how we feel, has nothing to do with what they do. It's just it's adding all these points that you're talking about. Now, one thing I am going to ask you, because I do get this question. We believe in, I know you and I have similar beliefs on this, give somebody a fish, they eat for a day, but if you teach them how to fish, they eat for a lifetime. I get that, but sometimes people just need some bait and some tackle. Okay, so let's go into this. You talk about photos. If I'm a young dentist watching this and I'm still using the wand camera, which is a great tool for single tooth, give me some simple bait and tackle. Where would I start in photography? Okay,
so you've got your intraoral camera. It's working great for you. Your hygienist might be showing 4, 5, 6 shots to a patient, right? Which is great. But again, you've just shown them 4 individual teeth, and you've taught them to think individually, right? So I think if you want to laugh, this. If you got nothing else, this. Mm-hmm. When I go to clubs, I don't really go on the road much right now just because of my new life. I'm here and I'm doing this kind of stuff, which really makes me happy. But when I do any clubs, I'm actually I created a course called iPhotography. Let's not worry about the camera settings. Let's not get confused. These things have cameras that are better than what we started with 10, 15 years ago. Right. So, you and I think identically, Kirk. We're like positive thinkers. You know the old saying by Henry Ford, if you think you can or you think you can't, you're usually right.
Right.
So I'm a can-do guy, and I'll look in the camera and say to everybody out there, you can do this, right? Mm-hmm. This is something you can easily do. All you need is a camera phone and a set of retractors and mirrors, obviously. Right. There's YouTube videos that are out there about how you can get better images. I'll be honest and say that I don't like a lot of them because they show techniques that are very difficult to use or incorrect or more circuitous than you need to be. I don't like to sell. I don't like to plug. I created a DVD years ago only because there was no other thing out there. There was nothing else out there. So I'm not going to plug it. I'm just going to tell you I have a DVD that shows how to capture amazing images. It just follows me around clinic for 45 minutes shooting images. But if you want to try nothing else, just shoot images. Just shoot. Right. Get a set of retractors, get a set of mirrors. Everybody was taught how to do them somehow, and just start shooting. And then I have a blog where people can go to, and if there's anything I can send to you that somehow you disseminate, it's just a simple post that I show to all my assistants on how you should be grading your images. You need to grade yourself, right? Like a good chef, no chef on earth mixes a soup and then serves it. And then they taste it, they grade it, they add what they need, and they make it better. Right. So I tell people shoot images and then objectively look at your images and say, oh, I got a lip here, the tongue's in the way, it's all wet, I missed the lateral, let me do this better next time. And going back to what we learned about the learning zone, don't do it on your existing patients. Take an assistant, take a front desk, ask them politely, maybe you give them a Starbucks card for stretching their lips out, and put them in a chair and start shooting images on them. If you're an associate in a practice, it may be more difficult because those aren't your staff members. And I'm sorry for using the word staff. I hate it. They're your team members. I would explain to your employing dentist that you can increase the productivity of the office, reduce stress, and help the overall flow. And that helps your value to the practice. And there's no employer on earth who doesn't want to see a team member take initiative. So I would just say to them, look, I want to start shooting some images. Do you mind if during lunch or after hours, me and one of the team members who's on the clock, by the way, they're not doing this for free, if we just start shooting some images? And you start doing that, they'll love you for it. and just keep practicing and do it in the learning zone.
Yeah.
So when you take it to the working zone, it's polished and it's better. Does that answer it okay?
Yeah, absolutely. It's a great answer, and I believe this wholeheartedly. I think you're just stuck as a restorative dentist or a specialist without the use of high quality images. And sometimes you just got to start, and when we started doing video years ago, we had a worldwide expert on video come and help us. And he said, look, sometimes you just got to start crappy. Just don't worry about it being perfect. Just start. And once you start, it's going to get better. And like you said, grade them and you'll find a way to make it better and better and better. And that's what happens.
And so, Kirk, if I can, whenever I give my lectures, I make it clear to everybody, I will never, ever, ever make fun of somebody for a bad image because they're the one who picked up a camera. They're the ones who put themselves out there. So no matter how bad your images are, and everybody who brings me an image goes, Glenn, I'm embarrassed. The ones who I worry the most about, Kirk, the ones I worry the most about are the ones who show me their image, and before they show it say, I don't really need your help because my images are amazing. And so, I'll show them to you anyway, but I don't need any of this stuff. My images are amazing already. Those are the ones I worry about because none of us should ever think we have nothing more to learn.
Right.
So if your images are garbage, awesome. You have an image. You took one.
Right.
Right? And if you don't have images, take junky images. Start.
Right.
And if you endeavor to get better, you will.
Absolutely. Absolutely. I couldn't agree with you more. I am always cautious of somebody that has it all figured out. I love the people on the learning path. Now, as far as, when you talk about the patient partnership, again, once you start with the photos, now let's give them a few steps as far as questions go, because I'm sure every clinician that's done this realizes it's a transformation in the co-diagnosis or relationship with the patient. But there are some go-to questions that you probably use that were your safety questions, that started this process. So what are your favorite questions to ask a patient? You've shared with us one of them already.
Yeah. So it's interesting because there's questions you have to ask before and after. So my favorite questions beforehand require a yes answer. I quote a lot of my teachers because I think it's valuable that we just don't say, here's an idea that I got from somebody else. And I don't. So if you hear me quoting names, I'm not trying to name drop. I think people deserve, the reference, if you will. So years ago, I learned from Michael Schuster down at the Schuster Center for Professional Development, which I went through back in '99, I think. Mm-hmm. Great guy, great teacher. He taught me that in order to get engagement back in the day, you had to sort of like talk to people beforehand and get a yes. You had to acknowledge. So if I say to you, Kirk, after the exam, hey, by the way, you have periodontal disease, and let me explain to you what pockets are. And here's what pockets are, and yours are 6 millimeters, and there's these bacteria. That's what I learned from you. You can't do that. You have to say beforehand, so Kirk, before we do our exam, tell me, have you ever been diagnosed with periodontal disease? The answer is no. I say, great. Ever notice your gums bleed? Have you noticed your gums receding? Have you noticed any teeth getting loose? I'm looking for that yes. Because if you say yes to any of those, odds are there's a problem. So that later on, when I do my exam afterwards, and I sit you up and go, hey, Kirk, remember before when we talked about the bleeding gums and periodontal disease and what that all means? Well, you heard me calling off the numbers. And notice I'm nodding like you're doing right now. Because when I nod, you nod. When you nod, I nod. And you know the studies that when you nod, it becomes a part of you. Right? Yes, it does. So when you say to a patient, do you remember when we talked about periodontal disease and all the signs and symptoms that we talked about, and they're nodding along? I said, when you heard the numbers that I called off, what did that mean to you? Right? Nobody does that. Right. We all say, you heard the 6? Well, that means you have periodontal disease. You say, when you heard me calling off the 6, what did that mean to you? Mm-hmm. And they go, I guess it's deeper than it should be, right? Now, if I didn't have that conversation before I did my exam about what periodontal disease is, what's a 6 millimeter pocket mean, what are the bacteria doing, then it becomes me trying to talk them into something. Right. If I explain it before I even know that they have it, so to speak, or that they know that I know they have it, right, then it's just an explanation. So later on, when I talk about it, now they connect to it a lot better. I can't get into the psychology of it, but you understand what I'm talking about. Absolutely. So when we talk about questions, I'm trying to set the stage later for my digital co-diagnosis. So I'll say at the initial appointment, when was the last time you had fillings done? Are any of your fillings more than 10 years old? Did you have any crowns done? Did you ever have an experience done where you had work done and you just don't feel like it's right? Do you ever feel like your bite is off? Do you wake up in the morning and find that your bite is different than it is later on in the day? I ask these deeper questions because if they say yes, then I'm going to go into a real quick explanation of what that could mean. Right. Oh, you do wake up in the morning and your bite's different. Does it take about 10 minutes for it to settle in? They go, yeah. I said, well, I can't say for sure, and we'll find out after the examination. But a lot of the times that can be related to X, and I'll explain it. So later on, I can reference back. Remember when we spoke about X? They go, yeah. Right now, the odds of them saying yes to whatever's going on. So the questions I ask later relate to the questions I ask at the beginning. Right. So if they say, yes, I have fillings that are 25 years old, I'll say, have you noticed any rust on any of them? They're going to say, of course, no. Mm-hmm. Right? And they might look at me like this. Oh, well, yeah, well, of course, I recognize that. The reason I ask is because old silver fillings are metal, right? And what happens to metal in a wet environment? Mm-hmm. And I'll just go like that, and they'll go, yeah, they rust. I say, great. So if you haven't noticed it, that's wonderful, but that's what you have me for. I'm going to go take a look later and see. Yeah. Right? And how does an amalgam break down? It basically rusts, but we don't use that term. So if I talked about it at the beginning, then when later on in the co-diagnosis, I'm going to say, hey, you remember we talked about rust? What do you think is going on over here on this filling? Mm-hmm. And they're going to go, yeah, it looks like it's rusting. I say, exactly. And a rusted filling, I don't know about you, but you think it's probably time to replace that one? They go, yeah. Yeah, how soon can we do that? Right? And then I'll talk about the bacteria getting inside and working their way underneath the rust. And I'm telling them honest, truthful statements, but I'm giving it to them in terms that create a visceral response. And that's all. And it becomes their problem. It's not me talking them into a filling. So the questions I'm asking are trying to guide them down the road. And all too often, the dentist gets into the case presentation and thinks that if the patient doesn't say yes there, that either they or the treatment coordinator dropped the ball. And the truth is, it all begins, whether you're a restorative dentist. I don't want anybody else to think that this doesn't apply to them. If you're a restorative dentist, a periodontist, an orthodontist, endo is a little bit different, right? But even so, you can sort of set up what their symptoms mean in a broader sense before you do your endo diagnosis. But all of this needs to be hashed out before you do the exam, quickly and easily. It only takes a couple of minutes, so that your questions you ask afterwards dovetail with what you asked at the beginning. Right. So for those people who don't know what to do at the beginning, just look at your dental history form and start asking those questions verbally without looking at, hey, do you have any teeth that hurt? Mm-hmm. Have you ever been told you have periodontal disease? When was the last time you had a cleaning? A good one that I like to ask, and it's on my form, was, on a scale of 1 to 10, how would you rate your current dental health? And if you rated yourself anything less than a 10, why? Mm-hmm. It's an open-ended question. And of course, invariably, every guy writes they're a 9. Why are they a 9? Because it's been 15 years since the last cleaning. And every woman writes that they're a 4 because they haven't been cleaned in 7 months. Right. So, but it's a great way of getting to that argument. And then the questions after the fact, a couple of good questions to ask are, what do you see? What does this look like to you? And I know I joked about the whole My Cousin Vinny thing, but you really have to do that. And you have to say to them beforehand, I know you're smart. I know you're not a stupid person, but I'm going to ask some very base questions to make sure we're on the same page. So please don't think I'm asking you because you don't understand. I just want to make sure we understand each other. So when you say to them, when you see this tooth and this little gray area here, what do you think's going on? Mm-hmm. You've just asked their permission to ask those questions. And you have to practice this, like I said. And one more little technique I learned, and I'll throw it out there, and it works no matter what your case presentation technique is. Before you present anything to a patient, you need to sort of sit down across from them like this, just lean back, your hands are on your knee, and look them in the eye and say to them, Kirk, I'm about to show you your images. Don't worry, there's nothing gross or disgusting. It's just your teeth. But I think it's important for you to understand that you're in charge. Mm-hmm. You're the boss.
Love that.
I'm the captain of the ship, but you're the owner of the ship. And it's my job to take the ship into port safely and honestly and carefully, and to teach you all the pros and cons of the path we might choose together. But at the end of the day, you are the owner of the ship. So if the quickest path or the best path that I think is good is not the one you want the ship to go on, just tell me. And we're still friends, and we'll talk about it. Because the only thing I can't do is put the ship up on the rocks.
Right.
Because that endangers me as well as you. But everything else we can do. And they get that. Because what happens is you're going to present your best care to them. And I learned this because of exit interviews I did with patients, which, again, I'm sure you talk to people about from time to time. But when patients would leave my practice, I would call them and I would do exit interviews and say, hey, just want to know before you leave the practice, this is not to talk you back into it, but I want to learn more about what made you want to leave our office. And I'm just going to ask you one question and I'll shut up. What can I learn about your experience in my office to make everybody else's experience better? And that's it. Yeah. And what I heard time and again from people who got treatment plans and then never came back was, I don't know, I love your office. I think you're amazing. But the way you wanted to do things, I wasn't ready for it right now. And I know that you really only want to do it that way. And so I figured I didn't want to insult you by asking you another way to do it because that's the way you seem to want to do it. So I just figured I'd go get another opinion. So when you then say to the patient, we're still friends if you want to do it another way, they're not going to leave your practice.
Yeah.
And it's very rare where that happens. But by giving them that permission to say, hey, you are in charge of your own dental health. Right? You're putting it back on them. And my job is just to help get you there. So I'm going to present you the way I'd do it if it was my family member or me. But if that's not what you want something different, then let's talk about it. And most of your patients are not going to do that. They're going to say, thank you very much, nod their head, and go to another provider. And you have to be honest and tell them that ahead of time. And the moment I started doing that, my case acceptance went through the ceiling. There are people who may not have started right away who would say, you know what, I'm not going to start now, but can it wait 6 months? And they might have gone to another provider thinking that maybe I wasn't willing to wait. So if you say that, it opens up a whole series of other conversations that you better be prepared for.
Right. And you're speaking to the whole thing where, try not to get good at answers, get really good at questions. And how I see this and the way you've described, you're asking simple questions, good opening questions, and then the more intimate ones come a little bit later, because I'm not going to tell you everything about me in the first question. As I warm up to you, I'm going to share with you honestly how I feel. And I would imagine that's a big part of the process. The other thing too, in the exit interview, it's great that you asked a question because a lot of dentists they don't want the feedback and they're afraid of it, but it's a huge part of building any practice. And you've done this now twice. You can make adjustments on how you're doing business and how to better take care of people, right? Yeah,
it's scary. We all want to talk. We all want to share our successes. Right. And one of the best things about Seattle Study Club is their failures workshops. Yeah. Right. Where you open up and show cases that failed miserably. Right. And it takes a safe environment and a good self-confidence to share failures. But if any dentist out there wants to be humbled quickly, go call 10 patients who've left your practice in the last year and ask them why they left. And you can't leave a voicemail. You can't do it by text. You can't do it by email. You have to call and call and call and hang up and call until someone picks up that phone. And it's painful. And I would argue, Kirk, that 99.9% of dentists don't want to do that. But if you do it, you're going to get great answers, and they're not going to be about you all the time. Right. They're going to be about your team. So don't feel like they're just going to rip into you. And I'd say of the 10 calls you make, 5 of them are going to be about something to do with finances that have nothing to do with you whatsoever, that maybe you could have worked out. And maybe 1 might be about you, but I guarantee you the majority are going to be at somebody in your office said something or did something or mispresented something or an experience happened that then you can work on and make better for everybody else. Yeah. And creating a true partnership with patients, you're going to need this feedback, because what both parties do is they fill it with information that they don't know. So, if you have a patient that leaves, you're guessing, and when you get that information, it just can calm you a little bit or a lot in this whole process. I love it, buddy. And it makes it easier to do if you're calling your new patients the night before their first appointment. Yeah. If you're calling your patients after a procedure, they're used to you talking to them. Yeah. So now go into that too, because that's important. A lot of people, I would say most people, don't do that anymore. And how important is that in both practices you've built? The old, you point your finger at others and three more are pointing back at you. So I'm not pointing fingers at anybody on this one because I get lax in it as well. But if you're having a problem with no-shows, late cancellations, do yourself a favor and call your patients 2 nights before their first appointment. Just do it one time. Don't delegate it to a front desk member. Do it yourself. It shouldn't take you but 15 minutes. If I told you that you could spend 15 minutes a day and take home an extra $150,000 a year, you'd be a fool not to do it.
Right.
And only like four days a week, right? So pick up the phone. If you want to do something right now, you talked about like bait and tackle, like get started now, right? You're on a boat. You're in the bay. You've got a rod and reel in your hand. Then all you have to do is pick up your phone and push the button.
Right.
There's no excuse why you can't pick up the phone right now and call today is what, Tuesday? Call all your Thursday new patients. And pretty much every one of us works Thursdays. So pick up the phone, call all your Thursday patients. And all you have to do is say to them, if you get a voicemail or you get them personally, hey, this is Dr. Krieger. I know we're going to be seeing each other. I have an hour reserved for you on Thursday for us to spend time together. Looking forward to our time. Just wanted to call and see if you had any questions at all for me before we met, and to let you know that if there's any decision makers in your family who want to be there, they're welcome to be there. Those two things. Just say those two things. If you get them in person, nobody's ever going to ask you a question, ever. And they're going to ask you maybe, well, why do I need to bring a decision maker? Well, sometimes there's things we're going to go over that you may want to relay to somebody at home. And it's always easier if I do it than you because I'll be able to explain it better.
Right.
Now, they may not bring somebody, but we all hate that. I just have to go home and talk to my husband about this. Right? So in the digital age, we can Skype them in, we can screenshot them, we can video record it. There's a whole variety of good ways.
Right.
But my point is that phone call needs to have an excuse. And that excuse is any questions and to let you know if there's any decision makers, you should bring them. They won't bring them. It's okay. But I guarantee you will watch your no-show and cancellation rate drop through the floor because in today's busy world, you just stood out.
Right.
You got attention. And they're going to go, and if they're at work when they get that phone call, I guarantee you that a percentage of them are going to turn to their coworker and go, that's my dentist just called me before I met him.
Yeah.
Right. And nobody's doing that.
Right.
And you want to stand out? Don't go spend $2,000 on a billboard. Make a phone call for free.
Yeah. Absolutely.
And Kirk, one more little fun fact. And
please,
if call your patients after procedures. You're going home at the end of the day. You did a crown prep. Someone's paying you a considerable sum of money for this. In ortho, it's even bigger. Pick up your phone and call your patient. And if you don't want to, let's say you're scared. You're not like me. You're not like Kirk. You're not the kind of person who's going to just pick up a phone and talk to somebody you don't know. I'm going to give you a little life hack here.
Please.
Slide dial. Do you know slide dial?
Slide dial. So you can leave a message and their phones never ring. Is that what it is?
Yeah. What it does is it skips voicemail. I don't know how they do it. You can do a free service or you can pay like some very, very minor amount, which I choose to pay. Because the free version I found doesn't quite work as well. But as long as I have a cell phone number and you're my new patient, I can just call you through slide dial. And what you do is you just use their app, you dial the number, and it says slide dial is now connecting you to Kirk's voicemail. And all you'll get, it won't ring on their end. It'll go straight to their voicemail, and it'll just say voicemail from Glenn Krieger or from whatever number. You can't use it from a landline. You can only use it from a cell phone. You might be able to use a landline. I don't know. I don't want to say that. But basically, if you don't want to talk to the new patient, just slide dial them and say, hey, this is Dr. Krieger. We're just calling to let you know I'm looking forward to our hour together. You got to let them know there's value to that time. Right. I'm looking forward to that hour together on Thursday. Just wanted to call and see if you had any questions or to let you know about the second person. If you have any questions, please feel free to email me at, I'm not going to invite them to call back my office because I'm inviting them to cancel, right? If you have any questions, my personal email is, right? You got to email me, but I know that I know you're coming, right? And some people are still going to no-show. Some people are still going to cancel. But I will guarantee you will see your no-shows and cancellations drop. And if you do it after procedures, I can tell you, I've had patients who are my oral surgeon's patients come in as new patients and tell me, oh, I love Dr. Barrett. He's such a nice guy. He actually called me the night he took out her wisdom teeth. Can you believe that? I've heard that maybe 20 times, 30 times. Patients care about this. And if you get upset that people are leaving your office, ask yourself why. It's not their fault, because people who are thrilled in a relationship don't leave practices. They stay. So what can I do better today or tomorrow to make my relationship stronger? And this is a phone call, not an email, not a text, not your front desk, but you. Yeah. So sorry I had to add that on there, Kirk.
Oh, buddy, I love it. I love it, because every little bit helps, and there's nothing more stressful. I don't know, maybe people would disagree. There's nothing more stressful in dentistry than empty chairs. I mean, because it's not no profit, it's negative profit when you've got an empty chair. So every little bit helps. And it's awesome too, because I think you're exactly right. The differentiator right now is our businesses that really care. It's not so how flashy or how cheap you are. It's somebody that really cares, and you see it every day when you drive around your community. How many businesses did you notice yesterday just driving around your community where you saw a salesperson or a customer that really, really cares, and it sticks out, and you say to yourself, I'm going to be loyal to that business for a long time, and that's so key in dentistry. What other, as we kind of bring this to close, this is fantastic. What other pieces of advice would you give a young dentist or a mature dentist on the whole partnership for greater case acceptance? Anything you've learned for sure in these last 25, 26, 27 years?
Yeah, I just think you have to always reinvent yourself. I think the person I am today, not figuratively, but literally, I'm a different person today than I was yesterday. Mm-hmm. I think the problem we face today, and it's kind of funny because I went to school and graduated dental school in 1992. Mm-hmm. I graduated Ortho in 2014. I was the youngest person in dental school. I started dental school at 20. Mm-hmm. I was the youngest in the dental school, and I was 46 when I got out of, 47 when I got out of ortho residency. I was the oldest. So I got to see it from both sides. And I think the educational system has changed drastically in those 25 years. And I think what's important for people like you and I to understand, or you and me to understand, is today's graduates, and if there are any experienced orthos or GPs or anybody out there who's over the age of 40, I'm going to just make that distinction, 40-ish. Mm-hmm. I don't think that we understand, at least I didn't until I went back to school, the educational burden that these new graduates are carrying with them. Mm-hmm. It's a different world. So for the newer grads out there, people who've been out of school less than 10 years, give or take, I feel your pain. I know where you are. I came out myself. I know the loans you have. I know the saturation of the market. I know what it's like to be in a post-2008 world, or post-2001, really. It really changed after the tech crash. Right. So I see it from both sides because I'm building a brand new ortho practice, and I built a practice in the mid-90s before the tech crash when I had 20-year-olds pulling up in my office in a Lamborghini because of their Microsoft stock in Seattle. Mm-hmm. True story. So for the younger dentists out there, I'm just going to say, for case acceptance, present your best care every time without exception to every patient. Mm-hmm. Don't try to become a master of everything. And I'm the guy who doesn't take BS. I don't give it. I don't take it. So don't look me in the eye and say, oh, my patients really want me to do their endo. My patients really want me to take out their wisdom teeth. They don't. They want to be seen by an oral surgeon. They want to see by an endodontist. And while it doesn't make me lots of friends when I say this, the truth is, if you follow the path of getting better and better at doing one thing and presenting care of one thing, your case acceptance is going to skyrocket. But if I've got a menu of 300 items I'm going to sell you, and you say to me which one is best, it's going to be hard for me to tell you which one's best. But if I come from a good place in my heart, if I'm honest, if I'm moral, and I've got 10 things on my menu that I can sell you, and I sell them over and over and over again, and my team sells them over and over and over again. There's no guarantees in life, but the closest guarantee I can give you in dentistry is that if you present your best care every time, you make the patient experience amazing, you reinvent yourself on a daily basis, and create an amazing interdisciplinary team that supports you, your patients, and your practice. So when they go to that office, they tell them what an amazing doctor Dr. Smith is, and how you're lucky to be with that doctor. The amount of dentistry you're going to do is going to blow your mind. And it'll be way more than you trying to take that patient who needs an endo and squeezing them into your schedule and then rushing into the other room to try to present care on the patient who needs you to present care now and running from room to room. And so I'm just going to tell you, 5 years ago, I sold my practice. When I bought it, I had 6 days a week, triple hygiene on Saturdays, doing every procedure under the sun. 3.5 years later, I did nothing in the house but fillings, crowns, implant crowns, bridges, and the occasional emergency endo when my endodontist couldn't get them in. 3.5, 4 years later, I got off every insurance plan except for one. I was working 3.5 days a week, Monday through Wednesday, 8 to 5, Thursday, 7 to 2, straight through. My weekend started at 2 o'clock. I came back on Monday morning with no emergencies because I did one thing and I did it well and made sure that they were provisionalized well. I made more money, took home more money, had less stress, and a shorter work week doing less procedures. You tell me why I want to integrate any other procedures into my practice. So with case acceptance, be a master of what you do it over and over again, and people will understand that. Does that help?
It helps a ton. God bless America and God bless dentistry. It's just it's an amazing profession, and you can call the shots and you can do it however you want to do it. That's what makes this so much fun. And you don't have to work yourself to death to do it. So, buddy, I am so grateful for the ton of really, really good stuff. And I'm just crazy grateful that you're carving out time for us. I know how busy you are. You got a lot going on. So I really appreciate it.
For you, Kirk, you're the man. Anything you want, you got it.
Buddy, I appreciate you. You've always been there for me. Even the Seattle Study Club, speaking of Michael Cohen's group, I couldn't talk that day. And sure enough, you're like, hey, you can't talk. I got you back. And I'm like, thank you, man. Appreciate it.
Yeah. And for everybody out there, just so you know, this guy standing in front of you right now, he showed up at a study club lecture across the country with like 103 fever and went on stage and did what he had to do. So if anybody out there ever says that they don't feel well and they can't go to work, this dude here is a living example of you do what you got to do.
Dude, it's an awesome. I feel blessed every day. So buddy, I really appreciate this. Now, if people want to get a hold of you, how can I get a hold of you? You have a private Facebook group. Can you just talk about that for a second? What is your private Facebook group? It's specifically for ortho. Is that right?
Yeah, I have a Facebook group. I think the hive mentality is, we have such easy access to it, right? We can all create a group of 1,000 doctors and ask questions. So I've got a Facebook group that's only for orthodontists because we talk about only orthodontic stuff. You wouldn't want to be there anyway if you weren't an orthodontist. But if you're an orthodontist, you can go to Facebook and just go to Orthopreneurs, like an entrepreneur, Orthopreneur, Orthopreneurs with an S.com is the blog. So it's orthopreneurs.com or Orthopreneurs Facebook group. And you just have to apply. I'm going to ask for verification that you're an orthodontist, so you'll just show me your website or a license or something. And then you can come in, and right now, as of this moment, we got 1,291 members. If you got a question about software, hey, I'm thinking about changing practice software. What should I go with? It's basically, think of it as a Yelp and a support group at the same time. So it's open and honest. I think it scares the heck out of manufacturers because now they don't control the information gateway. We do, but it's upbeat, it's positive, you'll never get made fun of. If you're a resident, I hope if you're a resident, you're watching the Best Practices show because you'll get a running start in life. And if you are a resident, share it with your residents because they should be watching this stuff. But yeah, tell them all about our Facebook group. And no matter who you are, you can go to orthopreneurs.com and read my blog that I post a few times a week. I'm going to eventually probably switch it over to dentistry in general, not just ortho. So just hop on board now, and I promise if you have questions, you can email me personally. Just send it over to my personal email, which is it's DOC, at KriegerOrthodontics.com. And I don't know if you've got a visual or graphic you can put up, but it's just KRIEGER, orthodontics with an S on the end.com. So doc at KriegerOrthodontics.com. I will always get back to you. I'd only ask you to give me a day or two to respond. But anything you have a question of, you want me to look at an image, send it. You got a question about practice management or anything, I'm always there for you.
Yeah. And this guy knows a lot of stuff, and he's hyper responsive too. So he will get back to you. So, buddy, I appreciate this so much. Stick around. I want to just chat with you for a little bit.
Sure.
And so many other things. So if you're watching this, thank you very much for watching the Best Practices Show. And if you enjoyed today, do me a favor, hit the share button. And until we see you next time, please keep watching the Best Practices Show. You guys have a great day. Thank you so much.